Dear students, we are now in this second section, analyze the example of Rwanda. Just after the 1994 genocide against the Tutsi, which claimed 1 million lives in 100 days, the killing resulted in 2 million externally displaced people, while many who stayed in Rwanda became homeless and internally displaced. This genocide was also perpetrated through rape by people who were HIV positive to ensure slow death by HIV for the victim, using HIV as a weapon of war. The burden of disease after the genocide were the epidemics of AIDS, malaria, and TB, and waterborne infection. At that time, life expectancy was 28 years. It was, and recently in 2018, it was 60.7 years. At that time, the proportion of people living below the poverty line was 77.8%. Now, in 2016, it was 38.2%. So the country have made great progress. But in the post-genocide period, Rwanda faced a lot of challenges. The deep social, economic, and political roots of the mass violence was still remaining. But on top of that, they were reinforced by a profound internal and external displacement, as well as a severe hunger and frustration, as the criminals were free, and the country was facing unprecedented criminal justice challenges without enough judges and lawyers. In the background of all this, the country was debilitated due to the loss of human capital, infrastructure, and institutions. Meanwhile, the foreign aid dedicated to Rwanda was diverted outside Rwanda to Goma camp in Congo, serving the genocidal government in exile there. This government of genocide in exile took the aid to reconstitute and rearm itself in preparation to re-enter in Rwanda and finish the genocide. History proved them wrong, but it was challenging time. This situation impacted health of the population, and we saw a spike in level of poverty and diseases. Under the new leadership, the country quickly began its reconstruction. The new government launched a national development plan in 1998 and the Vision 2020 in the year 2000, with a strong political will to develop the country based on human development goals and equity-oriented national policies focused on social cohesion, leaving no one out, based on equity. The leadership created better access to health through the community-based health insurance called Mutuelle de Santé, to break the financial barrier, because in this program, 25% of the poorest pay no premium and no money at each point of care. For people having middle income, they pay $5 per capita and per year in the household, and 10% at the point of care, 10% of the cost. And around 10% of the population pay $12 per capita in the household and 10% of the care at the point of care. This was also possible because of a strong promotion of transparency and accountability. It was not easy in the beginning to make people pay in advance without being sick. However, due to the fight against corruption and the fight for transparency, and also other process like district management through decentralization, it was a success. The accountability exists at all levels, even in district management. There is what we call imihigo and a pay for performance program at the district level. Mayors commit to key performance indicators and sign that with the President of the Republic. And they are evaluated in all districts once a year. The best district, the best performer, wins extra budget. This performance-based financing exists also in the health sector with the program called performance-based financing. It is an additional budget giving on top of the national budget and the money generated by the health facility. And it's given for each key services provided with quality. This extra money serves to improve the 4 S's. Remember, the staff, the space, and the system. But we can add another S for support, to support the vulnerable to get access to care. This augments the income of the workers, as well as maintaining equipment and infrastructure for better care and improved quality of services. So, through this performance-based financing, the health sector has improved the quality of services. The leadership supports the major social sector improvements and builds strategic partnership to attract foreign funds for health, as well as invest public money in health at the rate of $1.29 for any dollar of foreign aid. The country creates a new equitable health delivery model, where each district at that time had 3 community health workers elected by their peers and educated by the Ministry of Health. Now, today, we have 4 countries in each village. And we have 4 community health workers in each village. And the country has around 15,000 villages. There is 1 female community health worker for maternal and child health services called maternal assistants. There are 2 community health workers called binôme, a man and a woman, for common disease such as malaria, pneumonia, gastroenteritis, fever, etc. And a man and a woman, so they can always enter in the room without any ambiguity. They focus on health promotion also and sensitization, and they also identify the vulnerable. Community health workers are now 4 in each village, and the 4th one is a community health worker dedicated to early child development. Community health workers refer to health facilities that are health center, which is the 2nd level of health services provided by nurses. It is primary care services that include delivery and hospitalization of non-complicated cases. Health centers are staffed with general nurses, mental health nurses, and midwives. There is 1 health center minimum in each sector. A sector is around 15,000 people, and Rwanda has 416 sectors. And in total in Rwanda, there are around 500 health centers. The health center refer complicated cases to the district hospital where there are doctors, and few district hospitals have specialists. There is one district hospital in each district. The country has 30 districts. So there is a strict referral system that combined with the community-based health insurance and based on the administrative structure of the country, have increased geographic access for all the population so that all Rwandan walk less than 1 hour to get access to a health worker. This respects the decentralization model and give the mayor the power to make decisions regarding all health facilities under his or her jurisdiction in his district. Health systems need to be strengthened, bottom up and top down, and as shown in these two triangles. On the left, it represents the healthcare delivery model. The more than now 58,000 community health workers in the village are followed by around 500 health centers in 416 districts. And after that, district hospitals, there are around 38 district hospitals with one in each district at minimum. And themselves, they are followed by the referral hospital with specialists for tertiary care in the major cities. Those are university teaching hospitals or provincial hospitals. The triangle on the right shows the importance of evidence-based policies, the importance of human resource for health development, the need to foster leadership, as well as the necessity to collaborate to develop research capacity that are central to generate evidence-based decision-making for the country. The country took a three-step system strengthening approach. First, it ensured the health system readiness for the 4S. I repeat, it is staff, space, and system. And we can add a fifth S for support. By defining standards, performing gaps analysis, and practicing targeted investment in infrastructure, in human resources, in training, in research. Second, the country ensure the service quality improvement with a structural clinical accompaniment, mentorship model at facility level and community level, and formative supervision for the superior level to the next level. This means referral hospital to district hospital to health centers to community health workers. Third, Rwanda created the management and the system improvement structure by training and supporting district and facility managers, developing tools for information system for reports, ensuring the use of data reported in decision-making locally and nationally, and improving data quality. This brought fantastic improvement in health service delivery and consumption between 2000 and 2015. In one hand, high improvement, in the other hand, increase of the demand. Here we can see, for example, the reproductive health and the attendance to at least one antenatal clinic that increased from 92% to 99%. Almost every pregnant woman go to the health center at least once during pregnancy. This has also improved the delivery in health facilities with birth skilled attendee. Both increase from 27% delivery in health facilities after the genocide to 91% in 2015. And today, in 2020, it's above 95% of women in Rwanda who deliver with skilled birth provider in a health facility. With this drastic decrease in child and maternal mortality, you can see in this slide, this happened between 2000 and 2015 as a result of the system created in Rwanda that, I repeat, it's focused on the vulnerable to break financial barrier with a health insurance, to break geographic barrier, to create health facilities according to the administrative structure of the country. And the administrative structure is under the mayor, and you have almost an equal number of people in each sector. And when the sector is big or the district is bigger, you may have 2 hospitals in the district or 2 health centers in the sector. And on the contrary, the acceleration of wellness, this slide shows that between the year 1999 and 2000, the middle class and the poor saw no improvement in their status. Only the well-off experienced the socio-economic progress you can see on the slide. And this because at that time, the country was still struggling to keep peace and the genocide out of the country. But also remember, the first national plan for development was in 1998, and the Vision 20 built in 2000, in the year 2000. After that, it was implemented. And you can see in this slide that, on the contrary, the acceleration of wellness was among the poor. An economic growth strategy based on a preferential option for the poor has pulled 1 million Rwandans out of abject poverty. There is no magic to this success. And Paul Collier, with his development at TRIC, explained the Rwanda rapid sustained economic growth with dramatic improved health outcome, a very big poverty reduction, and a decrease in income inequalities. This is the basis that has created a better population. And I hope that you understand that Rwandan example is important for global health. Other countries have done that. But it's an example that economic condition, if you improve them, you improve the health. Equity, if you base your policy, your strategies on equity, you improve health. And the question now is often asked if the Rwandan success is replicable. Having witnessed it since 1996 and having contributed to it, like many Rwandan, I can say, yes, it can be replicable. Lesson learned on innovation and improvement embedded in the principle of equity as pillar of development and as pillar of the Rwandan policies and strategies can be replicated in other countries according to their specific culture, setting, geography. UJG now has the capacity to teach how countries like Rwanda, developing country, and others could achieve unprecedented advance in population health and poverty reduction using those principles. And what is important to know is that there are more than 100 research papers examining those scalable delivery intervention that are important for global health and has improved the quality of the population. Dear student, we have reached the end of the second section of this course. The third section, which will follow, is an introduction to global health equity. Thank you.